before we launch into Francesca's presentation, I'd just like to welcome everyone here and acknowledge the traditional owners of the various lands on which we live and work, and pay our respects to their elders past, present and emerging. And I do that on behalf of the University of Queensland and of course on behalf of all of us. I'm just going to spend a couple of minutes bringing you up to date on a few things in regard to interRAI, and then I'll introduce Francesc to make his presentation. In terms of interRAI internationally, there are important meetings coming up shortly. Some of you would be aware, some not aware, that the interRAI's production system is based around a committee called the interRAI Systems and Development Committee, and consists of about 15 interRAI fellows who meet 3 times a year somewhere on Earth, often difficult to get to, and spend 4 days at a time contemplating new initiatives and also reviewing any product that comes out of the fellowship. So new systems go through quite a long process of development. Usually takes a couple of years to get from an idea to having something workable. And that committee supervises that process. And it's a very busy meeting and very interesting if you're there, but it attends to an enormous amount of detail as well as some of the important policy and conceptual issues that are needed to get these systems working well. So there's a meeting coming up in France in a few weeks, and there's some interesting matters on the agenda there. One of the things that's really preoccupying interRAI at the moment is how artificial intelligence interacts with assessment systems and what that means for the future of how we do assessments. And we are working on a number of fronts on that matter, and you've already heard a couple of presentations in this forum about AI and how it might affect the way we conduct assessments. So that's interesting. Bridget's on the call from New Zealand. She's the kind of one of the 2 lead fellows in New Zealand. New Zealand's hosting, thank you, Bridget. New Zealand is hosting our next Inspire meeting for postgrad students and postdocs, and I think it's fully subscribed, and it's meeting, I think, late January. I think myself and Naz are going to the meeting to help with supervising the students. It's a 5-day working program which takes advantage of interRAI's data holdings, and the students endeavour to work on some data and produce a publication within the space of a week. Usually it takes some months after that to get it into a journal, but it's been a very productive process, and thanks to our New Zealand colleagues for hosting that. It'll be a lot of fun in Auckland later in January. In Australia, I think the main activity that's occurring at the moment is, which I'm tangled up in along with Tracy Comans and the staff at NARI and at UQ. We've just completed a review of the data ecosystem for aged care in Australia. It's not an interRAI project, but obviously things related to interRAI are very relevant to the review. We've completed that work on June 30. We're just tidying up our reports right now, and so there are a lot of recommendations around data, the way data is collected and shared in and beyond the aged care program in Australia that are sitting within that our reports, and they're currently being digested by departmental officers, and the outcomes of their digestion are uncertain, and it's not for us to speak about the recommendations at the moment, but obviously reform of the data ecosystem is a critical initiative for Australia as far as aged care is concerned, and obviously systems like interRAI are under consideration as a possible solution for some of the problems. So I'll keep you updated on that in the future. We should have some more clarity around where that's going the next little while, probably in a couple of months. We ran a trade booth at the Australian New Zealand Society for Geriatric Medicine in Adelaide a few weeks ago. That went very well. Geriatricians are important in the system, probably not to overemphasise their importance, but the opinions and the uptake of systems like interRAI by geriatricians often influence others. So it was important to get some exposure of interRAI to that group of individuals. It went pretty well, I think. We are working away on various projects within our group of fellows. One thing we're doing is building another flyer which explains, in this case, what the interRAI home care system does. What does it look like? What are the data? What clinical concepts does it embody, and what are the outputs? In other words, it delineates the caps, the scales, and the various screeners and other applications that are born out of the assessment. And surprisingly, it's very hard to find this information when you look at the interRAI websites. And when people make inquiries about these instruments, they do like to see a summary of what it is and what it can do. And we think this is going to fulfill a need. So we have a flyer like that for the LTCF, and now we've got one about to be produced for the HC, hopefully in the next 2 or 3 weeks. That will be available and should be on our interRAI Australia website. So thanks to our team for doing that. And I think that's pretty much where we're at. We're really hoping the next 6 months see some decisions made by providers, by government and others in favour of interRAI. We'll wait and see, but this is a pretty critical time for interRAI and its future in Australia. Enough of me. Francesc is our guest today. He's an ophthalmologist. We don't have that many ophthalmologists get engaged in interRAI, so it's a real privilege to have his interest and also presence here today. He was up till recently living and working in New Zealand and somehow got tangled up in the interRAI kind of effort. He might explain how that happened. And he discovered that interRAI assessments contain some important items that refer to vision in particular, but also other aspects of communication, and probably more importantly, a load of other collateral information that can be associated with the vision and hearing and other communication variables that is incredibly hard to get any other way. And I guess he'll tell us about why that's so important. It's just a good example of how interRAI systems can be, have many audiences, and we are trying in interRAI to make sure that these audiences take advantage of what interRAI has to offer. So currently, Francesc is an honorary associate professor at ANU in Canberra in the School of Medicine and Psychology, and he works in the Canberra Health Service as a consultant ophthalmologist. So he's going to tell us a little bit about himself, I think, and then he's going to talk about his research in regard to vision and hearing impairment in older community dwelling adults in New Zealand. So I'll hand over to you, Francesc. So thank you once again for being here.
Thank you so much for the invitation. It's a pleasure to be with you. And we will try to explain a little bit about the experience and the importance about vision and hearing and the work we have been doing with interRAI. So I'm an ophthalmologist. I spend my time doing surgery in the eyes. I also take care about penguins, which is a little bit different. And I also do aerospace research, among other things. But one of the things that for me is more important is to explain to the public how important is vision. So maybe you are not going to be listening to me, but definitely you're going to be seeing what I do. And what I did to do ophthalmology, because vision is so important. Around 30 years ago, my grandma was 91 and she was almost blind. And 30 years ago, doing cataract surgery was not so easy. A lot of people said it was not worth doing. We did the surgery and she lived 9 years more, which was amazing. And that's why I realized how important is vision and that I wanted to do ophthalmology. So one of the critical aspects is how important is vision. Because if we put it in perspective, if somebody would tell you that there's a drug, there's a medication that would reduce dementia 30% with no side effects and would improve vision, everybody would say like, wow, that's amazing, best discovery ever. And this is what happened. In 2021, there was a publication in the States that they made an assessment and they found the patient that received cataract surgery that got better vision because of that, they had lower dementia, and it was around 30%. And of course, from there, it comes the explanation about how important is the implications of vision in taking care of older adults, because definitely is all together. The function of the brain receives a lot of stimulation through the vision. We can be more independent and we can do more things in our life. And this is a correlation that is relating also with aging. We know that the prevalence of dementia is going to be more when we become older, on the same way that the cataracts. Cataracts are very common. I'm sure that all of us, we know somebody that have received cataract surgery, because we see that all the time. Patients above 80, 90% of them, they will have cataracts. And this is a big issue because it's going to affect quality of life. And that's why we do around 30 million surgeries a year, because this is the most common surgery. So how are we preparing for aging? Knowing that cataracts and knowing the vision is so important, one of the easy takeaways is to receive cataract surgery earlier, or at least check the eyes. In here I'm showing you my grandma, my other grandma. She is 99. And we also did cataract surgery. And she's going with her friends, and definitely vision is very important for doing daily life. So we're talking that only doing a cataract surgery that is taking sometimes 10 minutes can change somebody else's life. And you can see in the pictures here, patients that have white cataract, patients are almost blind because the cataract is so important. And this affects the quality of life, and this makes the life very difficult. So we know when patients have vision loss, it affects a lot, because 80% of the things we do is through the eyes. And we know that we have more risk of mortality, falls, accidents, depression, and dementia. It makes sense to think that when we do cataract surgery, we can make a big difference. And when I discovered and I heard about interRAI, I was very excited, because we wanted to explain how important is vision and hearing from the perspective of interRAI. Because one of the things that we assess is about vision and hearing. And we assess if the vision is good, if there are mild, moderate, severe deterioration, or when we have no vision and no hearing. So all the information we receive from interRAI, it explains a picture about how people live their lives. And this has big implications. Because when vision and hearing is not good, people is more lonely. We have more depression, we have more dementia, more falls, and this affects the quality of life and health. So one of the issues that we have is that older adults have more lower vision and lower hearing and other health problems, and we have more difficulty to go and check them. So what we wanted to do, we wanted to explain the epidemiology, how common is patients that have low vision and low hearing, how many of them use aids, and how often they check their eyes and their ears. And also what we wanted to do is to check the implications about these problems. We publish the information on the descriptive analysis that I'm going to present, and I think it's very interesting to have an idea about the implications. So what we did, we make an analysis comparing patients that may be in rest homes to home monitoring. We made analysis of around 50,000 patients, analyzing only a couple of years. And we were doing something very easy. We wanted to check how good is the vision and hearing depending on the opinion of the patient. I think that's remarkable and interesting, because at the end of the day, we want to have something easy that we can deliver. And it's very easy to ask a patient if they have good vision and good hearing, it's easier to ask and do other things. So with only this information of 2 years, we were able to range 50,000 patients. So which are the results? The result is around 20% of the patients explain they have big important hearing problems, and 10% they have vision problems. The most problems that we can assess is patients that have moderate and severe problems. Less important, also the patients that have no problems or minimal. This is important because sometimes patients can have minimal or adequate problems that if we could address them on time, probably we will get better outcomes. But definitely we see that hearing problems, visual problems are common. One of the other things that we found is that not everyone was taking care of their eyes and ears. So we found that in care facilities, we found around 10 to 20% less examinations. And this is remarkable because it affects a lot. In the moment that people are more susceptible to have more implications about lower vision or lower hearing is the moment that we check them less. Also, another part is that we found that 70% of the patients had visual aids, but only 20% had hearing aids, which is remarkably low. We published the results, and I'm just going to explain a little bit more about the things that I'm going to comment with you. So one of the easy things is the take-home message is to explain how is your vision and how is your hearing. And when is the last time that you checked that? So in here, we can explain, and you can see the graph of information that we did not publish about the implications of patients that had worse vision and the implications about dementia. So you can see in the graph that patients that got worse vision, they got higher risk of dementia. So having severe difficulty with vision will correlate with 166 times higher risk of dementia. And this was affecting more Pacifica and Maori ethnicities. We also found that patients with worse vision got worse communication. We also found the patient with worse vision were more dependent. We assessed that through the functional status. And we also found the patients got more mortality. So definitely we can see putting vision on the center of health, it has a lot of different implications. And we could explain all of that making different analyses of interRAI, which was very exciting. So if we want to create accessible healthcare with better outcomes, one of the things we have to try to do is we have to try to offer better vision and hearing care. With the information that we assess, we got longer assessments and assessing 4 years with a bigger analysis, we assessed almost 500,000 patients. These 500,000 assessments are very significant in a population of like New Zealand. We're talking about 5 million patients. 5 million people living in New Zealand. And this was consistent when we make the longer follow-ups. We found that 10% of adults have advanced visual problems and 20% they got difficulties that we could address them on time, probably would avoid a lot of other deterioration. We found as well that Europeans were complaining more about vision loss compared to other ethnicities. We're talking that this is an analysis of 140,000 patients, which is very significant. We found that the vision aid decreased a lower vision. From 80%, patients have good vision, to 30% patients have visual problems that are important. We also found that different ethnicities have different access to vision aids, from 80% European to 40% Pacifica and Maori. We also can see that there are similar disparity in vision aid use in hearing problems. So definitely we assess that both things come together. And why people have less visual and hearing aids? Related to that, we can talk about access and examinations of vision. So we found that 50% of patients with moderate vision, they receive the recommending eye examination once a year. So patients that really need it a lot, only 1 in 2 were receiving the eye examinations that we recommend. Also, we found that Maori Pacifica got less eye examination compared to other ethnicities. And we are talking around 20 to 30% difference, which is very important. We could see the eye examinations change depending about the impairment. So patients had worse situations. Sometimes they were receiving less eye care because probably there was less expectations to make an improvement. But important as well is the perspective about ethnicity, because they were coming with more challenges. So one of the points is that vision aids are more common than hearing aids. This could be related because vision aids are easier to access and they're easy to work with. Hearing aids tend to be more expensive and sometimes provide worse outcomes. Vision aids decrease a lower vision from 80% when vision is perfectly fine to 30% when we have big problems. We know that vision aids can help, but when the vision problem is very important, despite the fact that we change glasses, it's not going to make a big difference. Another important point is that vision aid changed a lot among different ethnic groups. Pacifica and Maori, they got around 40 to 50% use of vision aids compared to European 80%, which is a most likely explanation. We think that maybe there are access barriers and they could come financial, cultural, that can explain why some groups have more access and use more visual and hearing aids compared to others. And one of the things that is remarkable and important to explain is that only 1 in 2 patients receive the recommending eye examinations. So this is a good key point. It is important to check the eyes and do it at least once a year, because this really can make a difference. If we can detect problems on time, we can have better outcomes and we can improve some deteriorations that are related to health. We have been working in the field and we want to keep working with interRAI and other databases to try to explain, for example, the implications and the challenges of patients that receive continuous eye care. So for some problems, we have to do injections in the eyes, and we know that around 40% of the patients are lost in the follow-up because these patients, they have it very challenging to come to see the doctors. And it comes with problems of transportations, dependence, dementia, all of these that definitely affects a lot. So we want to explain and connect database of interRAI with other sort of databases we have available to try to explain the journey of these patients that have to receive continuous eye care. Because definitely that's one of the things we have to create awareness. We need the data to explain the importance of our vision. And this data comes easily through interRAI So definitely we can make a big difference working together. So vision is critical in daily life and quality of life. Worse vision, we have a lot of different problems. We have explained that to that. But one of the things that we also found is that patients that had no vision have better outcomes. And one of the possible explanations is that most likely is because we got very little patients that got in these situations. And sometimes when we make analyses, we make interpretations. And it's not the same analyzing 300 patients that analyzing 150,000. Another possible explanation, and there has been some discussion and new theories, is that possibly if patients lose vision earlier, can develop some compensation mechanisms. And this can be from the social perspective, having a better environment with coping mechanisms, but as well to have more time to adapt. One of the latest theories is that if we have vision loss later on life, this can affect more the quality of life. Has more implications if we lose vision when we're older than if we lose vision when we're younger. So this is remarkable because it's critical to detect vision loss at any time, at any moment. But if we can detect it in patients that are on home care, really makes a difference because we can address a lot of the problems that they have if we are able to see them. So we have to do more examinations of vision and hearing. Thank you.
Thank you, Francesc. That was really interesting, and I think the audience can see sort of how much power there is in having this information continuously available amongst those people that are using aged care services or living in resi care, those who've been through an eligibility process and so forth. So very powerful. Now, we have an opportunity for some questions and discussion. You can put comments in the chat if you wish. I'm not sure if anyone's done that yet, but no. But if anyone has a question, please put your hand up and I'll invite you to say something or put a note in the chat. I can start by saying it seems to me, Francesc, that there's an opportunity. You're pointing out the lack of eye reviews for people that already have established visual problems. Then I think you're implying that interventions earlier on in the progression of conditions may be, critically important, so you don't end up with substantial problems. Where would you focus your investment if you had more resources on that kind of mild to moderate kind of end of the spectrum, or building a much more comprehensive program of review for those that have already got established visual loss? I guess, without going on about it, it seems to me that there's people who have got severe problems, a certain proportion of them are preventable. I guess you'd know better than me. What do you think about that kind of dilemma about early or late intervention, if that was a choice you were confronted with?
That's a very good question. We know that 80% of the vision loss can be prevented if detected on time. So one of the best approach is detect vision loss as soon as possible. So probably could be easier, yes, to assess and focus most of the attention when we have moderate and early vision loss, because probably we can make more of a difference. But I think that one of the key points here is to be able to ask patients how is this vision and how is their hearing. So only with a simple question we can learn a lot, and probably we can look for solutions only asking patients. Do you have a complaint? Let's address it. So try to orientate and come with guidelines when a patient has a visual problem, a hearing problem earlier is going to make a big difference.
Okay. Now,
we have here several questions around, but maybe I can just try to, or Len, if you can just pass me the questions and I will try to give an answer.
Yeah. So who's got a question?
Lisa and Robin.
Lisa.
The question of Lisa is, has any other country used interRAI to identify vision issues? The other country has been doing some research has been Canada. And they use it mainly to talk about epidemiology. The results we got in Australia, some information we got to discuss with Len, are rather similar from the one of New Zealand and are rather similar to the ones of Canada. And we are talking that around 10% of the patients can have visual problems and 20% hearing problems. We have been the first ones trying to explain, using interRAI data, the implications of vision and hearing problems affecting quality of life. And we have been able to explain that when vision and hearing is not good, we have higher risk to have dementia, mortality, communication problems, and this affects quality of life. I'm just going to follow the question. Thank you, Lisa, for your question. I'm just going to follow with Robin. Is there any data giving different ethnicities to sight challenges? And have you looked at this data in relation to this? That's a very good question. We have been able to found that Pacifica and Maori, they have worse outcomes with more dementia when we have worse vision. We have the assumption that these ethnicities have more challenges accessing healthcare, which comes with less diagnosis, less early approach, worse outcomes, less operations, less way to manage and progress as treatment. But the challenge that we have is that we don't have so much of good data. That's why, interestingly, the information that from interRAI we got is the best one, more complete of all New Zealand. And we have been able to explain it in a different way. We can have assumptions, but when we have real data, we can really explain the story. And with interRAI, we can talk about that. Otherwise, it's only presumption. Very good point. Bridget is making another question. Is about 40% of the patients are lost in the follow-up. Is there any differences between community clients versus eight residential care residents? This is also a very good question. Unfortunately, we only have the big numbers and we don't know the story behind. We want to explain and we want to investigate more about what's behind. Likely, there are going to be more lost in follow-up in age residential care. And we have found that. We have found that in age residential care, residents receive less eye examinations and use less aid relating to that. So probably having patients in community can be better, but also we have to be aware when patients are in residential care, we have to be stressing about the importance about vision and hearing to make sure that we address that on time. That this is not something that people forget about that. So definitely we want to delve into knowing more about that because it has huge implications in the way we deliver eye care. Thank you. Lisa's making another question and he's saying, have you found that the vision issues is correlated to the rate of diabetes? This is also a very good question. We make some of the analyses trying to compensate diabetes, so in this way there would be no confounder effects. Definitely look reasonable that patients with diabetes are going to have more visual problems. We have diabetes problem related to the retina, but one of the main ones as well is we can see that the progression of cataracts can change. So definitely diabetes is likely going to have a lot of challenges in vision. But on the positive thinking, we can assess or presume that a lot of patients have diabetes in their eyes. We will take more care and they will receive more visits, like screening visits, eye examinations. So hopefully, if there's a vision issue, it can be detected earlier and addressed on time. Very good insights. What about high blood pressure? If I say correctly, we made the analysis and we were able to put high blood pressure as well out, like one of the confounders. So definitely we can assess and explain the vision loss by itself. It correlates with a lot of different problems. We think that vision loss, it can be rather straightforward, more related to diabetes than related to high blood pressure. We know that high blood pressure can relate with visual problems, more related to the retina, like vein occlusion, retinal occlusion, but this is not so common. Like we know that diabetes is a very clear correlation. Probably the implication of high blood pressure with vision loss is not so significant. Thank you.
Anybody else got questions or comments?
Robin is making another good question. Unfortunately, it's not easy to relate the data to diagnosis of cataract and macular degeneration. Perhaps there is an argument to be had to ask for vision loss to be added to pre-populated list of diagnoses in section 1. Very good comment. Definitely, we think the vision loss is very significant in quality of life. So if we can assess this information, definitely it's something that makes a big difference. Because thinking about home care or aged care, knowing that somebody has a big issue on vision is going to affect a lot the way that patients interact or the degree of dependence or independence they will have. And it has big implications. Taking medications by themselves, having falls, definitely is one of the key points that we have to consider in aged care. Now we live in a digital area. Everything comes through the eyes. And 80% of the information comes from the eye. So we can assess that, it makes a big difference. From another point, as well, we have different databases. So if we can try to bring together several databases, we can try to explain the story of patients. So communicated interRAI databases with others definitely is a huge opportunity to try to explain the journey of the patients and as well to see what we can do to help them. Thank you. Definitely vision and hearing is one of the key points about quality of life.
So I'm just asking you about progression, because one of the good things about interRAI assessments is they are done periodically. I can't remember in New Zealand if the home care ones are done 6 monthly or every year, but I think in resi care they're done quarterly. So you have an opportunity to see what changes happen over time, and I guess then you can ask the question how much of that change would be amenable to prevention or treatment. What do you know about that from the data you've looked at, or have you looked at that within this kind of cohort, these cohorts of people?
It's a very good point, Len. Definitely that's a thing to consider about the progression, because we can assess the progression of vision and hearing, but as well the implications. When the situation is worse, how is it going to affect the quality of life? It's a pending assessment that we have to do, and definitely we want to keep going into this direction. The next question is about Robin. What do you suggest when someone cannot afford aids? Older people often do not see if they will not get enough use of their investment. Good point. It's difficult. It's a difficult solution. We know that sometimes in residential care, in community care, older adults don't have the resources, which is a big challenge. And we don't have easy solutions, because most of the things, especially with hearing aids, are very expensive. And sometimes it's frustrating because patients don't see the benefit. And that could explain why hearing aids are less often used than vision aids. Vision aids, we can see if they work or not almost at the moment. Like hearing aids, they can come with a period of adaptation, they can change, patients can adjust or not. I think the public healthcare has to make assessments on the way that deliver this type of aids, and definitely to have more support with public funded aids and examinations, especially in older adults, on the same way that we have it for children, would make a big, huge difference. So I think we can create and make a strong case to support patients that they need this sort of aids. Thank you, Robin.
Okay, is there anyone else wanting to ask a question? If not, we might wrap up the conversation. Lots of really interesting insights there and some potential calls to action, I think, from what we've learned from New Zealand. We don't have much Australian interRAI data, very little actually, and I expect we'd see similar kind of results, but we don't have it, and we don't have any way to monitor what is happening in the Australian environment. When people are assessed for aged care programs here in Australia, there's some information about sensory loss, but it's not particularly elegant. It's certainly not as detailed or precise as what the interRAI assessments offer. So there's an opportunity for improvement there, perhaps. Let's hope we can do better in the future. So anyway, lots to say about that potentially. It's for me to thank Francesc for delivering the presentation. Really interesting. I know lots of other people will watch this subsequent to this meeting. So Lisa, our task usually after these forums is to organise this in the way of a YouTube video, and it will go up on our YouTube site, and we share the information on our LinkedIn and X dispatches, which we do several times a week. So look out for those opportunities. We've got a couple more talks planned. I think Bridget's agreed to give a talk late in the year about assessment protocols. She and I will work out when that's going to happen towards the end of the year. Bridget published a paper recently demonstrating how assessments can be done effectively using interRAI with amongst people that have got speech disturbances, which are obviously pretty common amongst older people. So that's a beautiful paper. I think we've shared that on LinkedIn recently if you want to have a look at it, but she'll talk about that later in the year. And we've got a couple of other talks planned between now and the end of the year, so we'll keep you posted. So thanks, Francesc, and thanks everyone for joining, and have a good day.
Thank you. Very interesting to talk with you.
For those of you listening to this conversation who may have further interests in interRAI systems, please visit our website, interRAI-au.org.